Okay, let's dive into this. Welcome, everyone, to today's Explainer. Today, we're looking at a truly fascinating medical mystery. I mean, it's a condition that perfectly bridges the gap between endocrinology and ophthalmology, thyroid eye disease. This is one of those topics that's just absolutely full of hidden truths, physiological quirks, and honestly, diagnostic traps that can catch even seasoned professionals totally off guard. So, we're going to decode exactly what happens when the body's immune system literally sets its sights on the eyes, and of course, how we properly manage it. Here's the blueprint for today's explainer. First up, the big thyroid misconception. Second, mechanisms and clinical signs. Third, activity versus severity. Fourth, diagnostics and risk factors. And finally, treatment and the surgical sequence. All right, section 1, the big thyroid misconception, busting the hyperthyroid myth. Right out of the gate, there is a massive trap that people fall into when thinking about this condition. There's this reflex assumption that thyroid eye disease only happens in the setting of active Graves' hyperthyroidism. So I want you to ask yourself this: can thyroid eye disease happen without hyperthyroidism? If you have totally normal thyroid labs, can your eyes still be under attack? The answer is a resounding yes. It can happen if you're euthyroid with perfectly normal levels, hyperthyroid, or even hypothyroid. This completely shatters the myth that the thyroid gland has to be actively overproducing hormones for the eyes to be affected. In fact, these orbital findings can precede, coincide with, or follow the onset of thyroid dysfunction by months or sometimes literally years. So never ever rule out thyroid eye disease just because those thyroid function tests come back normal. Moving on to section 2, mechanisms and clinical signs, the anatomy of orbitopathy. Now, if we zoom way down to the cellular level, thyroid eye disease is basically driven by autoantibodies. Specifically, TSH receptor antibodies trick the receptors expressed on orbital fibroblasts. But it doesn't stop there. There's a second pathway, the IGF-1 receptor, which forms a co-signaling complex with the TSH receptor, and it massively amplifies this inflammation. It's kind of like pouring gasoline on a fire. This causes fibroblast proliferation and the deposition of glycosaminoglycans, which is basically hyaluronic acid. Ironically, it's the exact same stuff people pay hundreds of dollars for in cosmetic dermal fillers to plump up their skin. But here, it's aggressively expanding your extraocular muscles and orbital fat. And here's the major catch: they're expanding inside a fixed bony orbit. There is literally nowhere for all that extra tissue to go. Because there's nowhere for that expanded tissue to go, it just pushes outward, right? And that creates a very specific set of physical clues. You'll see upper eyelid retraction, which we call Dalrymple's sign. You'll also see lid lag on down gaze, or von Graef sign. That outward bush creates axial proptosis, which is this frequently asymmetric bulging of the eyes. We also see restrictive myopathy, and interestingly, the inferior rectus muscle is the most commonly affected, followed closely by the medial rectus. That causes double vision and a real restriction in looking up or outwards. Plus, because the eyes are bulging and the lids are retracted, patients are at severe risk for exposure keratopathy, where incomplete eyelid closure can actually lead to corneal ulceration. Scary stuff. But as bad as corneal ulceration sounds, there is an even more critical danger lurking at the back of the eye: compressive optic neuropathy. Guys, this is an absolute vision-threatening emergency. It happens when those massively enlarged extraocular muscles crowd the orbital apex and, quite literally, strangle the optic nerve. You need to be on extremely high alert for this. If a patient experiences reduced visual acuity or red desaturation, where the color red starts looking kind of washed out, you cannot wait. No routine follow-ups here. This requires immediate escalation. Okay, section 3, scoring. Activity versus severity, mapping the damage. So assessing this disease really requires a keen eye to separate current inflammation from permanent damage. We have two totally different scoring frameworks that honestly get confused all the time. On one side, we have CAS, the Clinical Activity Score. This measures current inflammatory activity. Are the eyes painful, red, and swollen right now? A score greater than 3 means you've got highly active disease. On the flip side, we have NOSPECS. This measures the extent or severity of the disease, things like permanent proptosis, muscle involvement, or sight loss. Here's the trap. You can have a patient with severely bulging eyes and permanent double vision, meaning a very high NOSPCS severity, but zero active inflammation, meaning a low CAS.
Understanding this difference is absolutely crucial. It's exactly what determines whether you use medical treatments or if you need to go straight to surgery.
Let's dive into Section 4, Diagnostics and Risk Factors, Finding the Culprit. When you're trying to confirm your suspicions on a scan, you want to look for this classic high-yield imaging secret. When examining a CT or MRI of the orbit, focus on those extraocular muscles. In thyroid eye disease, the muscle bellies will be enlarged, but, and this is key, there is sparing of the muscle tendon. The tendons look totally normal. Now, if you see enlarged muscles, but the tendon is also involved and swollen, actually, scratch that. If the tendon is swollen, you need to completely redirect your diagnosis to idiopathic orbital meiosis. That tendon-sparing detail, that's your absolute biggest clue for confirming thyroid eye disease.
And while we're talking about culprits, we have to talk about risk factors. There's one that stands head and shoulders above the rest. Cigarette smoking is the strongest identified modifiable risk factor, hands down. It not only drives the initial development of thyroid eye disease, but it aggressively fuels its severe progression. Stopping smoking is a core, non-negotiable recommendation, literally regardless of what stage of the disease the patient is in. Speaking of severe progression, here is another massive trap you must avoid. If your patient has Graves' hyperthyroidism, a super common treatment is radioactive iodine, or RAI therapy. But administering radioactive iodine can actually precipitate or dramatically worsen thyroid eye disease. The risk just goes through the roof, especially if the patient is a smoker. So if you're going to treat the thyroid with radioactive iodine, you absolutely must protect the eyes first with prophylactic glucocorticoid cover. Treating the thyroid without protecting the eyes can lead to disastrous visual consequences. You've been warned.
All right, our final section, Section 5, Treatment and Surgical Sequence, the road to recovery. Now that we've mapped the damage, how do we actually fix it? Well, our medical toolkit is tiered based on disease activity. For mild disease, we use lubricating drops and, interestingly enough, selenium supplementation, which has shown some real tangible benefit. For moderate to severe active disease, where that CAS score is high, the first line is IV pulse glucocorticoids. But here is where modern medicine really shines, teptumomab. Remember that IGF-1 receptor pathway we talked about earlier, the one amplifying the inflammation? Well, teptumomab is a targeted monoclonal antibody that specifically blocks that exact receptor, significantly reducing proptosis. It's a real game changer. Finally, if we hit an emergency like that compressive optic neuropathy we discussed, we need urgent high-dose IV steroids, and if that doesn't work fast, surgical orbital decompression. Now, once the disease has finally burned out and entered its stable, inactive phase, we have to fix the residual structural damage. And this requires a strict, fixed surgical sequence. You literally cannot mix these up. Step 1 is orbital decompression. That creates space and fixes the proptosis. Step 2 is strabismus surgery, which aligns the eyes and fixes the double vision. And step 3, performed last, is eyelid surgery. Why this exact order? Because every single step directly alters the anatomy for the next one. Think about it. You can't fix the eyelids until you know exactly where the globe of the eye and the muscles are permanently positioned, right? Let's pull this all together. So the crucial point is really captured in these non-negotiable facts. Thyroid state doesn't matter. It can be euthyroid, hyper, or hypothyroid. The most affected muscle, the inferior rectus. Your ultimate imaging clue, tendon-sparing muscle enlargement. Remember the scoring distinction. CAS is your active inflammation, no spakes is your permanent severity. And finally, that rehabilitative surgical sequence is always decompression, then strabismus, then eyelid. I want to leave you with one final thought to really test your medical detective skills. If a patient is about to receive radioactive iodine for Graves' hyperthyroidism, what critical step must you take to protect their vision? Think about it for a second. You must provide prophylactic steroids. Otherwise, you risk triggering a devastating progression of thyroid eye disease. By keeping these key mechanisms, traps, and sequences in mind, you are perfectly equipped to understand and navigate this incredibly complex condition. Thanks so much for joining me on this explainer, and keep questioning what's right in front of you.